You've probably heard the term cardiopulmonary resuscitation, or more commonly known as CPR for short. But what exactly is going on when we're doing CPR? How is this going to be beneficial for the patient? And why is it so important that you understand these concepts? That's what we're discussing in today's video. Before we jump in, I just wanted to take a minute to remind you to hit the subscribe button, turn your notifications on so you're notified of any future videos that we post. If you have any questions over the stuff we're talking about today, leave us a comment below. We love hearing from people and interacting with y'all in the comments. We're hoping that you get some good information out of this video, and if you do, we'd really appreciate a like on this video. That would help us out greatly. All right, so let me start off with a disclaimer. First off, we are going over some CPR principles today, and then we're going to be applying them in different scenarios. But as we talk through this, there's going to be some information and data that's not completely aligned with the guidelines of AHA or Red Cross. So you have to remember, when AHA or Red Cross puts out guidelines for CPR training, they have to figure out what can do the most good for the most people in the audience in which this training is intended. For example, we're going to talk about pulse checks. Pulse checks are not recommended for lay persons, and we'll explain why that is a little bit later in this video. So that being said, just remember this video is not a replacement for actual training. So always seek out proper professional training, and this video is for informational purposes only. When someone has a cardiac arrest, that means that their heart arrests or stops working. That person will become unresponsive, and in a matter of minutes, their brain cells will start to have permanent damage. If immediate interventions do not take place, these patients will not have a good outcome. And the specific interventions that we're talking about are CPR, or cardiopulmonary resuscitation. You've probably seen CPR on a TV show or a movie. You may have even witnessed it firsthand. You may have even, hopefully, taken a CPR class at some point. But some people go through the motions and they understand we push on the chest, we do some mouth-to-mouth deal, and somehow this helps bring a person back that was otherwise not responding to us. And while some of that is fairly true, it goes a lot deeper than that. So we're going to take a look at exactly what we're doing when we're doing CPR, how that's affecting the body, and how that may or may not fix whatever medical or trauma issue that patient has. My goal with this video is to give you a better understanding of exactly what you're doing, so as you're doing CPR, if you're ever called on to do that, you can then alter what you're doing and the care you're providing to be able to understand exactly how that care is benefiting this patient. For example, we say do compressions. Well, if you just do compressions, but you don't understand how important it is for the consistent compressions and how we're trying to keep that blood pressure elevated with compressions, it may not sink in your brain of how important that is, how time off the chest is potentially causing brain damage. And so hopefully after this video, you will be able to put all these things together and have a much better and deeper understanding of CPR, and you'll be better able to respond to a CPR if you find yourself around a cardiac arrest. So before we jump into CPR and how to perform CPR, let's back up for a minute. Let's look at some physiology and talk about the different systems in place that provide life to our body. First off, we have our respiratory system, which is our lungs being able to bring air in, which has oxygen in it, 21% oxygen in the air. We take a deep breath in, our chest wall expands, that negative pressure draws air from the atmosphere into our lungs, that oxygen diffuses into our bloodstream, and then our cardiovascular system takes that oxygen that's now in our bloodstream and it circulates it through the blood around to the cells that need it. Our ultimate goal is to get oxygen and glucose and a bunch of other stuff, but bear with me, oxygen and glucose to the cells. That is the fuel for the cells, including brain cells. And if the brain cells don't have oxygen and glucose, we're gonna have a problem. So for simplicity's sake, let's just talk about oxygen, since that's one of the key factors that we need here. So we have the respiratory system that brings oxygen from ambient air down into the lungs and goes into the blood system. But let's talk about the cardiovascular system. The cardiovascular system, first off, has the heart. The heart is the pump. Every time it beats, it propels blood through the body. That keeps this circulation going. Let's think of that as the engine that is driving this. Then we have the railroad tracks of the blood vessels. We have blood vessels leaving the heart to take oxygen and blood out to the cells, and then we have railroad tracks to bring all those train cars back to the station, back to the pump to get circulated again. Now, our cargo is oxygen cells. So let's say that red blood cells specifically are the train cars that are transporting our precious cargo from the lungs through the heart, down the rail track to the cells. They dump off the oxygen at the cells, return back empty to the lungs, get more oxygen when we breathe in, goes back through the heart and gets propelled out to the body again. And that cycle happens over and over and over and over. If you want a more detailed look at the physiology and exactly how this works, we did a video on that in our physiology series. We'll put a link in the description below, so check that video out and that will give a much better detailed description of exactly what's happening in that circulatory process. All right, so we know oxygen comes in from the atmosphere, goes through the lungs, gets into the blood, and ultimately ends up at the cell. Now, our brain is a sensitive organ. If it doesn't get oxygen for a few minutes, it will start to die. So that is why if we have an issue with either the blood circulating or the oxygen moving into the body or some issue with getting oxygen to the brain, it's a matter of minutes before we have brain cells starting to die. All right, so that was a brief overview of some physiology. Just remember this, we have to get oxygen from the ambient air into our cells, and specifically right now we're talking about brain cells, since those are the first ones that start to die and the ones that we need to make sure we keep oxygenated. So let's take a look at CPR now. What is the process of performing CPR on an unresponsive person? So first off, we do CPR on an unresponsive person. We are doing chest compressions on someone whose heart is not beating. There are a few exceptions to that when we start talking about infants and pediatrics, but right now we're talking about an adult. So if an adult's heart stops beating, that blood is not circulating, we take over that by pushing on their chest to manually push the blood out of the heart, allow recoil, allow the heart to refill with blood, and push it over and over and over. We essentially are taking over the job of the heart by pushing on their rib cage, which ultimately pushes pressure on the heart, propelling blood through the vascular system. But let's back up for just a minute and run through the actual process that we would be going through on a CPR. So an indication that someone needs CPR is that they are truly unresponsive. When we come and approach a person, for a lay person, we're going to do just shake and shout. We're simply going to try to shake and arouse the person, wake them up. We're going to shout, "Hey, are you okay? Can you hear me?" And if we get no muscle twitch, no response, no moaning, no movement, nothing, then we start CPR. The way that a medical professional is taught in these classes is to do a pulse check for no more than 10 seconds. While we're doing that, we're also listening and feeling for any breathing. So the difference here is a layperson that has not been taught how to properly check a carotid pulse, or if they have been taught how to check for a carotid pulse, there are a lot of times where they will check and they may either feel their own heartbeat because they're not using the right fingers to properly assess for a pulse, or they question themselves because they're not comfortable with checking for a pulse, and so they end up either not doing compressions or starting compressions on someone that didn't need it. But the worst part is when they have someone that may need CPR and they're just not sure if they are feeling a pulse, and so they're hesitant to even start CPR. So that's why that's been taken out of the layperson's guidelines for CPR. So we did the shake and shout. We've determined that they are unresponsive, not responding, and so we're going to jump into calling 911 and making sure that someone is getting an AED if there is an AED nearby and available. After that, we move into chest compressions. We use both hands and we push on the lower half of the breastbone or the sternum. So if the breastbone goes from here to here, we're going to be pushing on the lower half. The heart sits directly underneath that. So when we press down and compress the rib cage or the sternum right there, it's going to push on the heart. It's going to push the blood out of it. When we release and let off the chest, it allows that heart to fill back with blood again. There are one-way valves in the heart that keeps the blood flow only moving one direction, but this is like a bulb syringe now where you are squeezing and it's pushing blood out, and when you open it up, it allows blood to come back in from the opposite direction. You push, it propels it one way, allows blood to come back in, and every time you push, you're pushing blood through that system. Now, the heart has stopped beating, so we're taking over the process of the heartbeat by pushing on compressions. Keep in mind, our chest compressions are nowhere near as effective as if the heart was beating on its own. So we're doing very poor to mediocre circulation of the system until that heart can take over and actually circulate properly again. If a person has had a heart attack, their heart has stopped beating, most likely due to a dysrhythmia. Their heart has gone into a weird electrical rhythm or has stopped having all electrical activity in their heart, which has caused the heart to stop beating. The big thing that we need to do to fix these people typically is to start that electrical activity again, and that can be started with an AED. So when someone applies pads on a patient and shocks them, typically that is the ultimate fix to jumpstart that heart and get the heart beating again. So remember here, chest compressions are buying us time, getting oxygen to the brain, keeping the brain cells from dying until we can put an AED on and shock the heart and get the heart started on its own again. I want to pause for just a minute and talk about an AED. An AED is safe because it's reading very specific cardiac arrhythmias that AED can shock. You can't simply put an AED on someone like me, fully alive, hit the shock button, and shock somebody. These have a bunch of safety features built in so that it has to detect these very specific dysrhythmias or arrhythmias that need to be treated with electrical shock. So just because you have one on a wall, don't think that it's now a danger because people can just take it off and shock someone that doesn't need to be shocked. All right, so what about mouth-to-mouth or breathing for these patients? Well, mouth-to-mouth, they've taken that out of just about every guideline you're going to find for CPR. The reason being is because there are a lot of diseases that can be transmitted mouth-to-mouth. It's not the safest for the person that's providing care. It's also not necessarily the safest for the person that's receiving the care, in case the person that's actually helping out has diseases that are transmitted. When someone becomes unresponsive, they still have oxygen left in their vascular system. And so by doing CPR, we're taking whatever residual oxygen is there and moving that around the body. So we have a little bit of time before we actually need to perform a ventilation or breathing for this unresponsive person. Professional rescuers are trained to use a device such as a BVM or a pocket mask to be able to deliver ventilations to this person, and then they can also hook in an oxygen tank with some supplemental oxygen. So even the poor compressions and the inadequate breathing that we are doing for the patient that's not near as effective as the patient doing it on their own, we can still increase the amount of oxygen that's being absorbed into the body and try to keep the brain cells alive. So at this point, once we have chest compressions initiated, we have an AED on and we've hit analyze to check to see if this person's in a shockable rhythm. And if we are a professional and we've already initiated the breathing for this patient, the next step is going to be IV or an IO. We're going to start pushing some cardiac drugs according to the ACLS algorithm, and some of these other medications can have an effect on the body and give us a greater likelihood of being able to shock and get this person back. But the key essentials here are immediate chest compressions and early defibrillation with electricity if the AED says to do so. All right, so we've talked a little bit about physiology and how oxygen gets from the air that we're breathing down into the cells where it needs to be. Then we talked a little bit about an overview of CPR and what we do when we're providing cardiopulmonary resuscitation to an unresponsive person. Let's talk about a couple common disease processes and injuries that may cause someone to go into cardiac arrest, and then how us doing CPR on these patients is going to benefit them and help them in this scenario. So first off, most common, heart attack. A heart attack is a myocardial infarction. Myocardial means heart muscle, and an infarction just means that we have death of that heart muscle. So we have a blockage somewhere that's preventing oxygen from getting to these cells. Remember, we talked about all cells have to have oxygen. Different muscles and different types of cells respond differently when they don't have oxygen. For example, I can put a tourniquet on my arm, and it's about 2 hours before the muscle cells in my arm begin to die. we only have 3 to 5 minutes with brain cells. A heart is also very fragile and it needs oxygen. So when we have a blockage that prevents blood flow from going into the heart or a certain part of the heart, that part of the heart will start to die. And we have part of the heart that's dying and that heart is contracting. Well, now part of that heart is not contracting as much. And eventually we can even lead to a arrhythmia. So instead of a normal electrical impulse causing that heart to beat, we can get a weird quivering or a weird arrhythmia in the heart that's preventing that heart from having a proper contraction. The way to clear these weird arrhythmias out is to shock them with electricity. It clears all the electrical impulses out of the heart, and then hopefully the heart will then restart with a normal beat, and then we will have a heartbeat back on that person. So again, the primary thing to keep in mind here is early compressions so that we keep that oxygen circulating, and then ultimately our fix is going to be a shock to try to shock this person's heart back so that we can clear out that weird electrical activity and get a normal heartbeat established. Well, what about a pulmonary embolism? This is a blood clot that goes into the lungs. The heart's doing just fine, the circulatory system's still working, but the problem is when that blood flows back to the lungs to pick up oxygen, there's a blockage. So some of that blood can't make it through the lungs. And there's not enough oxygen coming through the lungs being diffused into the blood because there's a blockage of the blood. So this is an obstructive shock. Unfortunately, most PE patients have a very poor outcome, and this is something that's very hard to resuscitate somebody if they have had a large PE. We're going to go through the same algorithms. We're going to do chest compressions. We're going to try to keep blood circulating. If there's an arrhythmia, we'll shock for it. We're going to do the same thing. Our care doesn't change, but the outcome for these patients is typically not very good. All right, what about somebody that has choked and cannot get air into their lungs? So someone has been breathing, something has occluded that airway, the heart is still circulating until the point where there's not enough oxygen left in the blood that's circulating because it's not picking up anymore from the outside, but there's no oxygen left to go to the heart starts to get ischemic, which means it doesn't have oxygen. And so the heart muscle starts to slowly slow down to the point where there's not enough oxygen and the heart doesn't have enough oxygen to continue doing what it needs to do. If the person's still responsive, we do the abdominal thrust to try to push pressure on the lungs to expel that object from the trachea where it's lodged, hopefully open up that airway. If the person's unresponsive, we're going to do CPR. And when we're doing chest compressions and when we're trying to ventilate as a professional rescuer, we are trying to not only keep that blood flowing, but also hopefully will eventually displace that object. If we have a paramedic or doctor, they can also try to get a direct visual on the obstruction and be able to use some forceps to be able to pull that out of the airway and open the airway up. Sometimes by doing CPR, it will dislodge that obstruction, allow oxygen back in the lungs, and then hopefully we can get that heart restarted after oxygen is introduced to the system. This same process works for a drowning. There's a wet drowning and a dry drowning. A wet drowning is when you get water down in your lungs, and that's not as common as a dry drowning. A dry drowning is actually when your vocal cords will spasm because water hits them, and our bodies will tend to spasm to try to keep that water out of our precious airways. And so a lot of times they will spasm shut. It won't allow any water in, but it also doesn't allow any air movement because it's trying to keep that water out. So a lot of times a drowning may be a dry drowning, and given enough time, those vocal cords will eventually relax. We can then do CPR, and we can continue to provide oxygen from the ambient air down into the blood, circulate the blood, shock them if needed, and try to revive these patients. What about low blood sugar? Well, the problem is not oxygen in this case. Remember we talked about needing oxygen and glucose. So we can do CPR, and it's going to be a pretty low chance of getting somebody back until there's actually sugar on board. And so we're going to need to call 911 and have EMTs or paramedics deliver this through a IV or an IO and be able to get this sugar on board so that now our brain and our heart have both oxygen and glucose to be able to survive. But keep in mind, nothing changes in our algorithm. Just keep keeping the circulation going, put an AED on, keep providing that same care. You're buying time until a professional can get there to start an IV and administer these things. All right, so here's a big one that's been discussed a lot lately: overdoses. and specifically an overdose with some sort of narcotic, whether that's fentanyl or heroin or whatever the flavor of the week is. When we have a narcotic suppresses the respiratory drive, which is that drive that makes me want to go. We do this every day, all throughout the day, without even thinking about it. And we have a drive that wants our body to breathe. I'm thankful that we have that. But if we have something that suppresses that, our body no longer wants to take those breaths. And eventually, we're going to become hypoxic, low oxygen is what that means. And then eventually, we're going to have our brain is going to make us go unresponsive, our heart's going to stop beating, and it's going to be a bad day. The way that we fix these patients is by CPR. We do chest compressions if there's no heartbeat, and then we also can ventilate these patients with oxygen to be able to get these systems functioning again. There's a lot of talk about Narcan, and while Narcan can help block these narcotics and stimulate a respiratory drive again, if the person does not have a heartbeat, simply giving them Narcan does not fix them. We can do CPR to circulate blood, and then we can do ventilations with oxygen to be able to get oxygen back into their system to revive this person. And then ultimately we'll have to give some Narcan at some point so that person breathes on their own, but we can ultimately start breathing for this person with the BVM. But if you're not doing CPR, simply giving Narcan to somebody is not going to magically fix them if they don't already have a heartbeat. Now, what if the issue is blood loss? Let's say we have a trauma patient and they've lost a lot of blood. The heart's still functional, the vascular system, the train track is still there, but we've lost the actual carriers of oxygen. This blood has been spilled out and we don't have enough blood. If we don't have enough blood, you can do CPR all day long. You can shock if it says shock, but you're ultimately not going to be able to revive this person because there's no blood to transport this oxygen around. So these patients are very critical. We need to make sure that we are stopping any bleeding. That's why tourniquet application and fast tourniquet application in someone where this is warranted is so important. And these patients will need a blood transfusion in order to resuscitate them. One more trauma incident that we'll talk about is a tension pneumo. Now, a tension pneumothorax basically means that we have a collapsed lung for some reason. We have a hole in the lung, that lung is collapsed. It has lost the vacuum or the seal around the lungs that help keep that inflated and stuck to the inside of the chest wall. So we've lost that. So the lung is collapsed and now we have a pressure buildup inside the chest. So if one lung is collapsed, we can still breathe off the other lung for a while. But the problem is every time we take a breath in, the air goes into the lung. We try to breathe out. It's like a balloon. It acts like a one-way valve. It allows air in but not back out. And so we have a buildup of pressure inside the chest. As that pressure increases, it starts to deflate the other lung because it's putting pressure on it. It starts to actually push on the heart and decrease some of the circulation in the heart, and that can lead to a cardiac arrest as well. Now, if we had a patient that had a tension pneumo and we do CPR, we might be able to buy some time and be able to circulate some of that blood to keep oxygen moving. But the ultimate fix is that we have to deflate that chest. And that's a skill that a paramedic or a physician would do by putting a needle into the chest or a chest tube into the side to allow that pressure to escape. If that doesn't happen, we're going to have a really hard time doing CPR and actually being able to resuscitate this person because we have not fixed the original issue that caused this CPR in the first place. If we don't fix that issue, we're going to have a hard time resuscitating this person because we have not fixed the original issue that caused the cardiac arrest in the first place. So keep in mind that nothing changes for CPR based on what the disease process was that brought about the CPR. As a layperson, you're going to do the same thing. Shake and shout. If they don't respond, you're going to begin compressions. This buys time until professional responders can get there. But just understand, unless we start fixing that thing that caused the heart to stop beating in the first place, whether that's an electrical abnormality in the heart, whether that's blood loss, a tension pneumo, low blood sugar, whatever that is, we have to fix that in order to resuscitate the person. So it's important for all bystanders to understand how to do CPR. If you see someone unresponsive, check and see if they truly are unresponsive and start initial compressions. Grab an AED if there's one close by, put that on there, and shock if it indicates to do so. Don't delay calling 911, because if it's one of these other causes other than just an electrical abnormality or a myocardial infarction that moved into this cardiac arrest, we may not be able to fix them immediately with chest compressions and an AED. Those chest compressions will definitely buy us time, but we may need the EMS crew or a physician or someone to be able to do some other procedure in order to be able to resuscitate this person. Overall, the percentage of successful resuscitations in a cardiac arrest patient are very, very low. I believe they were around 4% at one point, and there are some places in the nation that have more of a 15 to 20% success rate, and in those places, they have done some studies and started implementing things in the community that have led to that greater success rate. One of the biggest things that led to that success rate is bystander CPR. By having someone immediately begin CPR, whether that person's gone down in public or at the home, if someone initiates immediate chest compressions and gets that process started, that buys time and keeps the organs alive long enough to allow EMS to get there to be able to provide further care to the patient. Because bystander CPR is so important, we have seen a lot of school programs that have started incorporating CPR training into the high school. So as a kid comes out of high school, they've been through at least 4 CPR classes over the course of the past 4 years. This makes your community much more aware and ready to respond in the event that they come across a cardiac arrest. Since bystanders play such an important role in resuscitation of a cardiac arrest patient, having an AED readily available is a big deal. And so some of these places that have better success rates have better community programs where they have AEDs readily available, whether it's in stadiums, in malls, shopping centers, churches, schools, parks. We are seeing more and more of a trend toward having a lot more AEDs readily available for the public to use in the case of a cardiac arrest. We've seen too many people that have been hesitant to give CPR because they're not sure if they're getting a solid pulse check. They don't know if they're feeling their own pulse. They don't feel something, but they're not sure if the person may have a pulse. So we've seen a shift away from actual pulse checks for layperson and just going to shake and shout. So we've seen more people willing to engage in CPR by the shake and shout method rather than having to positively identify whether or not there is a pulse. A lot of lay people are also confused about breathing for a patient during CPR, and a lot of people are hesitant to give mouth-to-mouth resuscitation for a person, especially a stranger. So they've taken that out of the layperson guidelines and said, at a minimum, at least get chest compression started. That circulates any residual oxygen that's in the body. Get an AED on, contact 911 ASAP. Shock if the AED advises. Keep doing that, and that will buy some time until professionals can get there. If you're trained to use a pocket mask or a BVM and you happen to have one of those readily available, definitely a good idea to use that. Remember, that's a 30-to-2 ratio, 30 compressions, and then give 2 breaths. On the medical professional side of things, we also have made some slight changes to the algorithm that we use for cardiopulmonary resuscitation, and one of those includes using faster airway adjuncts. So rather than taking the time to fully intubate a person that is unresponsive, we have some other tools like eye gels now that simply size it up to that patient, slide it in their mouth, and then use a BVM to ventilate. This allows us good access to the lungs so that we can ventilate properly at a fraction of the time it would take to get all the equipment out to put a endotracheal tube down. All right, so as we bring this to a close, hopefully this helped you to understand a little bit more of the physiology that's going on in the body and some of the pathology that we're talking about when we're talking about cardiac arrest and why we're doing cardiopulmonary resuscitation, or CPR, on these patients. If you have not taken a recent CPR class, let this be a reminder now to go do that. Go check out the AHA or Red Cross websites and look for some trainings in your area. If you have the option, I would try to take a CPR class from an ambulance crew or a hospital or some healthcare professional that has some experience in CPR. If you jump through the right hoops, you can become certified to teach CPR without actually having the experience of doing it on a person. While that's beneficial to be able to get the word out there to more people, it is very beneficial for you to be taking a class from someone that has firsthand experience and does this on a regular basis. So as they answer your questions, they can give you some real world feedback on things that have worked or haven't worked. And we at 6 Echo have put out a lot of training videos, and we have a CPR video overview. You can find that on our YouTube channel. We'll also put a link to that down below as well. So go check that out immediately, and then have that be a reminder to go follow up and find an in-person class for you to take soon. Well, that concludes this video, and as always, stay vigilant and stay safe.